Thank you so much. It's really an honor to be here. And of course, I'm going to show you patients who have all 4 Rs and still come to me and say, I don't want to have surgery. Can you help me? Which is what we do every single day, right? So here we are. I have no relevant financial disclosure. So my main disclosure is that I've been doing this for over a decade, and I'm faced with these patients every single day, just like many of you. And we now have 20 years of innovation in non-surgical tightening, from our first monopolar RF device through different variations of devices, stamping devices, continuous movement devices, radiofrequency needle delivery devices, fractional subdermal RF, and all these combo devices, which we saw at one point with lasers and IPL, and now muscle stimulation. We have ultrasound devices, and new things exploding onto the market all the time. And we have our tried and true fractional CO2 and traditionally ablative CO2, and now mechanical microcoring. What's more, adding another tool to our toolbox is that all these other procedures like injectables and sutures, absorbable PDO threads, and even body contouring procedures have skin tightening effects in their own right. So all of these things can also be used. So what are the criteria that we use to decide, when all of these things are exploding onto the market, what are we going to reach for, and what ends up in what we joke is our laser graveyard, right? Like things we just don't reach for anymore, and why? And this is my opinion and my practice. I have all of those technologies. I practice in a large group in a major metropolitan area, so I have those things at my disposal. But my patients want to know, what should I have? Is it worth this recovery? Should I have surgery? Should I pay for that one large procedure? So in my opinion, the efficacy must be clearly superior if it's higher risk. If there's obvious social downtime or pigmentation or some other complication, if there's severe pain and we have to sedate that patient, if there's higher cost to the patient, either financially or in time, if they keep coming back to your office and spending a lot of time. Reasons for that, or examples of that, I would say, are these long dwell needling radiofrequency devices, or let's say these RF devices like the bipolar and multipolar RF devices, where you just had to keep coming, 6 to 8 times. Maybe for a modest improvement, I might not have my patients go through that. If I'm going to do this to a patient, these are my patients, long dwell time RF microneedling, this is a surgical recovery. So I really have to justify this with a stellar result. I have to wow that patient. Other things, if there's company or service issues, or if the patient just doesn't like it. If they don't like it, you're going to hear about that on social media. And so every day people come in and they say, well, what should I do? Should I do this or should I do that? Last year you told me to get radiofrequency needling around my eyes. This patient has lid ptosis, brow ptosis, periorbital fat prolapse, volume, all things going on. She's early 40s. She doesn't want to have surgery, and she's asking me what to do. But now she comes in for treatment, and there's this new device. Which one's better? We have no head-to-head studies. So she's a brave soul. She let me do half a split face, 2 treatment protocol, RF microneedling versus synchronous ultrasound parallel beam. And here are our results. We put her in Visio. We asked her feedback. We looked at the photos. She looks great. She said, I'm going to choose the treatment without the recovery, and I'm going to do that every single time, and I'm just going to apply subsequent treatments and combine this with other treatments like injectables. Would her results be different with monopolar RF? Here's a similarly aged patient without the fat prolapse, but she has really nice results after just monopolar radiofrequency treatment, and we have long data and consistent results with these devices. Microfocused ultrasound, we can get consistent, subtle, modest improvements. We know how to get good results with this. We know that we're getting these focuses in the SMAS, in the dermis, of collagen remodeling, and that if we apply adequate density, we're going to get nice improvement. Patients in their 30s, 40s just tightening alone. Here's a monopolar RF, similar results, subtle tightening. Early 40s, synchronous ultrasound parallel beam, really nice subtle lift, upper lip, full face. You can see where I treated her here from the front. And so we look and compare these ultrasound tightening devices. We have HIFU or MIFU versus parallel ultrasound beam technology. You have very focal coagulation pinpoint zones of collagen remodeling in the dermis and the SMAS with HIFU, and you have more volumetric heating in these cylindrical injury zones in the dermis with parallel ultrasound beam technology. And so we have to wonder, can we get more of a focused, deeper lift with HIFU versus more texture in creepy thin skin areas with parallel ultrasound beam? We don't know because we don't have head-to-head, but common sense would say maybe there are sweet spots for each of these, and maybe we should look at thinner skin areas, periorbital areas, upper cheek, brow. Here's a patient who had just those things around the brow, eyelid, and lower face, subtle texture, and she came back at 3.5 months. She was underwhelmed. We looked at her again at 5.5 months and said, you're ready for another treatment, but you got even tighter. So we know that this device, specifically with all that volumetric heating, does continue to remodel for longer. So our follow-ups for these should be a little bit longer than for our focused ultrasound. Here's a patient in their 50s just tightening alone, 3.5 months after. And when we apply subsequent treatment, just tightening alone, we get even more improvement. So do we need time, or do we need a more aggressive procedure in recovery? So these no surgical, no downtime RF or ultrasound, we know we can get great results, very subtle tightening, remodeling, rejuvenation. It's consistent. Patients like it. Most important thing, patients like it. It's safe and it's easy. There is a time and financial investment, but at least we know we can get mild and modest improvement. Up to 80 to 90% percent of patients report being satisfied in studies. And I have to ask myself, well, is that gratitude bias? Would a paying patient go home behind my back when they're at cocktails with their friends and say that they were satisfied with this subtle improvement? So we did look at this, and we were curious. We looked over 3 years, 2016 to 2019, anonymous survey. We had no way of knowing who responded until they come back and told us later that they filled it out. But we did see this. We were able to replicate this. Behind our back, about 80% of people say they see mild to moderate tightening from just tightening alone. But we know that it's not just the skin. I use the table and tablecloth analogy. The tablecloth is getting longer, while our table, our muscle, our fat, our bone is shrinking. So with the anatomy, we're going to need either a bigger table to make more of an improvement, or a higher table, and we're going to have to account for that. So we have all these tools, multi-layer structural rejuvenation. When we combine these things, we can really streamline recovery and get safe and effective combinations and get much more dramatic results. Because we know that just toxin, just injectable filler, can give us even a lifting and tightening. This is 50s patient, neck, just toxin. This is at early, just turning 30, early changes, just filler, 40s. And then this is 50s, just filler and a little fractional CO2 for texture on the nose. We have great evidence for this. I'm a fan of dilute CAHA, but you can also use PLLA, HA, and get some rejuvenation. There's a whole growing body of literature on this, comparing these and looking at the different changes. But what I'm really interested in is this. This patient actually filled out that survey I told you about at 1 year, and she was one of the 20% that said she didn't see anything. And so what's really cool about this is she's still my patient now, 8 to 9 months later. But even her here at 4 years after, we only did filler 1 to 2 times a year, and we reapplied the tightening at 2-year intervals. And I have a protocol for this, but it is evolving because we don't know exactly what is the best interval at different phases in life, and skin and anatomy changes. But what we do know is that there's a profound synergy between injectables and energy-based devices. And this article in 2014 by Dr. Casabona changed my practice. Much stronger trichome and collagen remodeling after combination treatment. And we used to say it's possible that these devices degrade or melt product, and now we know that we just get this priming of the tissue and much more dramatic remodeling. And we know that the product is somewhat stable. There's also a body of literature on this. After 5 or 6 months. And a recent article just last year, this I thought was very cool. They were trying to tease out a little bit more about timing. So here's a facelift patient. You can see here microfocus ultrasound same day versus just microfocus ultrasound and CAHA and hyaluronic acid versus applying the ultrasound a month after filler versus just microfocus ultrasound alone. And the best results were clearly 2 different types of filler and microfocus ultrasound same day, followed by 1 type of filler, microfocus ultrasound same day, followed by applying it a month after. So I was telling my patients, we have this window, the product is still there. We can do your tightening, in a month, in 2 months, in 3 months, but it may be that we get the absolute best results if we do at least some injectable on the same day. So again, my practice is changing as of this year. But we can really wow a patient. This is a single session. Again, a different ultrasound device, but similar results, slow over the course of 2 years. I'm clearly arguing for time here over recovery and aggressive procedure, but I do think we can make a huge dramatic difference. This patient just came back to see me. We were barely maintaining her with just 1 syringe of filler and 1 area of toxin per year, and now just by doing 1 syringe of CAHA and tightening on the same day, a year later, she's finally better. And I think that's really impressive. And sometimes we do everything. Here's a patient that said, I'll do everything that's non-invasive, but I don't want to have surgery. So we did injectable fillers over the course of a decade. We did laser, we've done radiofrequency microneedling, we've done thread lifting, and these threads, they do degrade over the course of 6 to 9 months, even the thicker barbs, but they have a very high melting temperature. They're breaking down on their own, and aside from not wanting to disturb the tissue by doing a treatment, they're not going to just melt. And it's possible that there's even similar synergy, and that you're going to get even more dramatic improvement when you do those together. Microfocus ultrasound plus filler. We got to a certain point. This patient said, but I still have, she called them jowlettes. I still have jowlettes. And then we finally did this PDO thread lifting. 6 to 8 weeks later, we applied further microfocus ultrasound on this patient, and we've gotten some nice improvements. Thin skin on the body, dilute filler, PDO thread mesh, and then either synchronous ultrasound parallel beam or monopolar RF. Again, cryolipolysis, ultrasound or RF tightening, and dilute filler. I also use droplet deoxycholate in combination. I'll do 0.05 to 0.1 cc per injections. This was a cellulite subtle laxity patient. Again, combination for the win. You could do a PDO mesh. You'd think I didn't do microcoring in my practice, but I actually do. Where does it fit in? Do these results justify the recovery? And we're going to hear a little bit more about that in a moment, but are there specific indications to consider? When you have severe laxity, scarring and laxity, or maybe that really stubborn spot. This patient came back to see me. You see it here, really stubborn. I'll combine this and I'll put all the recovery together. Fractional CO2, microcoring in different spots to get one recovery and some improvement. This patient wanted no injectables. This device I'm not going to cover because we're out of time, but I will tell you, is there a role for high-intensity electrical stimulation of the muscle in addition? I think so. I think you're going to hear a lot about this. Why bother with all of these treatments, 4 treatments to stim the muscle? Is it even durable? And I think it is. You're going to see some animal histology, human histology, and clinical studies, including MRI data at this meeting presented, showing that these small muscles of the face may be enmeshed in connective tissue and may actually continue to improve for months after, more than what you'd expect from just muscle stimulation on the body alone. You're targeting some facial muscles here, and I'm going to wrap this up, but I think this is exciting as well. And the photos here, you can see some volume in addition to tightening, and it seems to also cause adipocyte apoptosis and some fat improvement as well. So thank you so much for your time and attention.